Missed our latest webinar? No worries. We know life gets busy, but your professional development shouldn't have to wait. That's why we've created webinar micro lessons. Short, focused recaps of our full sessions designed to help you catch up quickly and still earn your CPD points. These bite-sized lessons are available exclusively to active subscribe members. So even if you miss a live session, you never miss out on the knowledge or the CPD points. Not subscribed yet? Now's the perfect time to join. Get access to all future webinars, every micro lesson, and more. Visit www.clinicalcareplatform.com to sign up.
Year-old known epileptic is in the ED following a seizure. And while awaiting further assessment, you are called to see them for another seizure. You perform the ABCDE assessment, which is airway, breathing, circulation, visibility, and exposure, ABCDE. Secure the airway, so you intubate the patient, and you give them 4 milligram of IV lorazepam, which is otherwise called Ativan. Blood glucose is normal. After 5 minutes, the patient is still seizing. What is the most appropriate next step? Is it A, give a second dose of Ativan, B, monitor for 5 more minutes, then a second dose of lorazepam? Is it C, transfer the patient to the ICU, or is it D, a phenytoin infusion? So the concept that they are testing here, guys, status epilepticus, okay? So they want to know what's your approach to status epilepticus.
I wonder what the answer is. Good evening, colleagues, and I hope you are well. It seems like this week I'll be seeing you or you'll be seeing me every single evening, at least until tomorrow. So I'm so excited because during the day I do miss you as well. During the week, if I know that we only have 2 sessions, I'm like, ish, I'm gonna have withdrawal symptoms. Let me just, before I start, confirm that I'm never alone. I always have backup, and there we are. We are with Dr. Rochelle Adams. Hi, Doc. Are you well?
Evening, Lesego. Hi, colleagues. Yes, I'm well. Thank you.
Thank you. Thank you. It's always a great honor to have you on board. Colleagues, if you give me a little bit of stress, know that I've got Dr. Rochelle, And when we are together, we can't lose any challenge, any battle. So yeah, I'm looking forward to tonight's educational session, and also to those of you who are joining us via social media platforms. Welcome to you as well. Here we have Alain, we have Pumla, Philip, Gretel, Zola, Kolisiwe, Dr. Kuzwa, are you there? Leonard, welcome, 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 colleagues. Paulina, yeah. So we have a Admire, welcome, welcome, colleagues. This is the clinical care platform. Let's get going. A few things. I need to just change my screen so that even those who are joining online will be able to see my slides. Let me see if I still remember how to do it. Yeah, I hope you can still hear me. Yay! So let's go to the slides. Give me a few seconds. I need to just press on my Zoom there. Yeah. So a couple of quick slides. It's always a marathon because it's never about me, but I just need to make sure that you know exactly what's happening. We always have new people joining us. And just to remind you that as a platform, we have a mission, which is to improve patient care. Very, very important. And we want you to learn, change your practice. Learning, we can only see it when you change how you care for our people, but also continue to share with many more health workers so that more and more people can be empowered. We have, achieved a great milestone in August, over 120,000 CPD credentials issued to you, especially our members. And I also want to say thank you to collaborators like my dearest Dr. Rochelle, because I can never do it, alone. We can never do it without you guys. So we really appreciate you. We are a membership-based platform. I think today, as soon as Dr. Rochelle has done the theory part, I'll show you a few things about membership, giving her some time to take a deep breath before we go through the Q&A, so that if you do have questions as well about our membership program, you can get a chance to ask me those questions. I committed myself that every session from now onwards, I will share a leadership note, because I'm growing myself in this area and I feel like I must empower more and more people. All I want to say is that in life, both the good and the bad are looking for us. At some point, they do get to us. Whether you are a good person or a bad person, I can tell you, you will experience problems, you will experience pain, you will experience bad experiences, So all of us, we go through that. What differentiates other people from others is when now you have to make the choice. Am I going to allow this pain, this problem, this situation to define me? And I want to encourage you to not allow it to define you. Take a positive life stance at life. Define this problem, see what you can learn about it. Try to see what is it that you need to change, and make sure that you are in control of your life. I know there's a quote which I see every time. It says, sometimes you win, sometimes you lose. I want to tell you a different one. Sometimes you win, sometimes you learn. And here at CCP, failure is never an option. We always choose. We believe that we are in control of our lives, and therefore, no matter whatever comes our way, we always come out as winners. And for you to remain a winner, do join us for some of our diploma preparatory programs in HIV, in telemedicine, obstetrics, child health. Colleagues, I can't wait to host you in October. So we are still open for registration, and you still have almost a month. We decided to open these registrations in time so that you can plan ahead. But I've got good news. We've got new programs: diploma in anesthesia, preparatory program. We actually have 2 instructors in this program. I'm so excited. And also diploma in ophthalmology. And for those who like surgery, I can assure you something is cooking in the back end. We have an awesome surgeon who might be taking you through either part 1, part 2, or even intermediates. I think the platform is heading in the right direction. Don't miss this weekend. Yesterday we had Dr. Ryan teaching us about the polyneuropathy. I can't remember. A lot of neurons and stuff. But all I can tell you, this Saturday, we have a masterclass on neurology dermatology. It's the final of the FCP Part 2 programs. I'll share the links later. Next week, we are with the nurses. I am the instructor for the NIMART program. It's in person. I'll share the link. If you are a nurse, you have joined for PEP, but you are not NIMART trained, please join me next week. Otherwise, do complete it online if you can't get to Johannesburg. We're gonna finish August on a high note. It's Women's Month. Let me tell you two things that are happening next week. Next week, there's a unique webinar I'm going to host around this bed and how to manage pain, directed at women in healthcare. So I'm hoping you guys on Wednesday you'll join me. It's gonna be a little bit different. It's not educational, but it's more about self-development and empowerment. And we finish next week Saturday dealing with cervical cancer prevention and management. So yeah, a lot is going on. I know Rochelle has a lot for us, so let me stop talking and just really appreciate Rochelle for always making her time to join us here on the platform to empower us. Sometimes colleagues, you see slides and you see people teaching here. I know what it takes to prepare to come and teach health workers. It's a lot of hours. So we don't take that for granted here at the platform. I know I can read your profile, Rochelle, but all I want to say is to say thank you very much for your commitment and for impacting so many health workers. And may the Lord richly bless us, so that this relationship is protected and it continues to enable health workers, to do great things in their lives. Yeah. So on that note, can I hand over to you, Dr. Adams?
Thanks. Thank you. Thank you so much, Lesego, for those kind words. And colleagues, can we all just give a big round of applause and thank you? I'm really appreciative as a member of this platform, coming sometimes once, sometimes twice a week, just to be here. One man's vision is empowering many. I'm also a part of his leadership. His leadership WhatsApp group and colleagues. I think that this is a wonderful platform for you to come to learn, to be empowered. And I'm so honored to be invited to be here. So I'm going to start by sharing my screen.
Awesome.
Let me know once you can see that.
Yes, it's coming through. Yes.
Can you see it?
Yes, you can put it on full screen. Yes, now we can see it fully. Thank you.
Okay, wonderful. So colleagues, last night we had Dr. Ryan on and I was on there, and honestly, my mind was a bit, I took lots of photos trying to get through that. And I think every time I come in here, I'm hoping I'm going to finish my slides, and I'm hoping that, some key takeaways that we can get, because, just in the approach to this training and thinking about healthcare workers on the ground. So if we look at the resources that are available, right? So this was the 2020 guideline that is still in effect. We've got the SAH, and this is the NDOH guidelines. We've got the SAHIV Clinician Society guidelines that were released in 2023. Last year, WHO released their PEP, HIV PEP guidelines. And so I also want to take notes that a lot of what we're going to be talking about is going to come from these training slides, which were developed. Just to note that our PEP guidelines are currently being redrafted. The process had started a couple of months ago. And so when you look at some aspects of the NDOH PEP training slides that I showed you, they differ slightly from the 2020 NDOH guidelines. They aligned more with WHO's PEP guidelines and the SAHIV Clinician Society. So what we think is we're going to see a lot more alignment that's going to happen. And so in preparing for this talk, there's some aspects of the clinical we're going to talk about. There's some aspects around the system that I also wanted us to also think about as we're gathering tonight. So let's hope this works. We're going to start off with some polls. Okay. So this is our first poll, which is looking at the risk of HIV transmission. The poll is open and I'm going to continue to speak. We'll give you about 30 seconds. And when you look at the different ways that HIV can be transmitted, this is not all. I've excluded blood transfusion and vertical transmission here. Which ones of these are the correct regarding the risk of HIV transmission by the mode of exposure? Percutaneous healthcare workers, this is your needle stick injuries. Insertive anal intercourse, this is whether it's MSMs or females. Receptive anal intercourse, penile vaginal receptive intercourse, or needle sharing, this is people who inject drugs. We've got 97, we've got 20% of you that have participated. I'm going to give you 10 more seconds and then I'm going to end the poll. And we're going to come back to these at the end. So in the running now, we've got needle sharing, which is 1,000 per 10,000 exposure, 10,000 exposures. I'm ending that poll. So there we go. It just shows that large parts of you think that needle sharing followed by receptive anal intercourse. Okay, I'm going to go to the next poll. Please help. Listen, I don't know what I've done. I kind of like have frozen my screen.
Yeah, you can just stop this one. Did you see the results?
Yes, I did share the results.
Okay, you want us to move to the next one?
Next one, yes.
Okay, we are now on poll 2. Colleagues, the risk of transmission following occupational exposure by means of sharp injuries is highest for hepatitis B, followed by C, then HIV. So basically, which one has the highest risk? Do you agree this is the sequence or not?
So this one is a lot quicker. So we're down to 20 seconds. So we've got yes is in the running, leading by about 75%. I'm going to give you 5 more seconds and then we'll end the poll.
Okay.
There we go.
I'm
So
ending
most
it.
of you feel, most of you feel this is the correct one, that the risk is HPV, HCV, HIV. Thank you. Can we go to the next one?
Yeah, do move on the slides as well so that those who are joining alternately can also see the questions. Yeah, so we are now on 3. Yeah.
So can the first dose of HIV PEP be given before the HIV test? We're giving you 4 options. Yes, no, maybe, I'm not sure.
Okay.
Where we on? That is
This one will always be conflicting, I know.
Conflicting, yeah. So it's neck and neck, okay? Between yes and no. Looks like no is
Let me stop.
winning in this regard, okay? So the majority feel that the answer there is no. Okay, we can move to the next one.
Okay, number 4. Which regimen
is preferred for the HIV exposed persons if they're 10 years and weighing 30 kilograms and no contraindications? I was getting happy there for a second, hey? I'm so happy. I'm very, very happy. So we've got...
But beware the dilution effect.
Yeah. Okay, we've got 200 of you that have answered.
Stop.
TLD looks like it's winning. We can stop that.
Yeah.
Thank you, colleagues.
Okay, 2 more colleagues.
Next.
Yeah.
Yeah, we've got 2 more questions. And so this question is around the blood test that we do for the HIV exposed person who starts on PEP, right? So in a 24-year-old female who started on TLD as PEP after unprotected sex, do we do a hepatitis B surface antigen routinely? So we've got 74% that are saying true, 30% that are saying false.
50%.
Answers are coming more
I
quicker.
think we'll stop
Yeah.
at 50%
We'll
before
stop
we
at
get
50%.
diluted. It's like a horse
Okay.
race.
All right. And we're
Okay.
down to our last question.
Okay. If you're joining us on Facebook, just type there in the chat, colleagues. We will be able to see your selection.
Oh, Facebook is on. Oh, wow. Technology. Ne? So this poll is around needle stick injuries and hepatitis B post-exposure prophylaxis. And so if we've got a healthcare worker whose hepatitis B surface antibody titer is 8 units per mole, and the source's status is unknown, which of these is correct? So here we've got it all across the board, hey?
All I can say is high risk. That's what I can say. That's my interpretation.
That's your
Even if I don't know the
interpretation.
guidelines, I'll say high risk and go and check what others do. Okay.
We
Okay, I'll
can
stop.
stop the poll.
Yeah.
Okay. So this is more of a mixed bag than all of the others, but it looks like vaccination is leading the pack, standard vaccination. Great. Thank you.
Okay,
So
cool.
now let's move on. So while we're talking about post-exposure prophylaxis, you guys know the data that's here around our incidence. So we have, according to the Tembisa model from 2023, about 408 infections a day. I don't have more current data, but as of October 2024, we were at 96, 79, 94 based on the 95, 95, 95 UN AIDS targets, right? And when we're looking at that in regards to subpopulations, we can see that children are faring the worst, right? And that 82% of females are on ART, 75% of males, and there's still a small proportion of those that are on ART that are also unsuppressed when we're looking at adult males and females. And so this is also a little bit old, right? This was from HIV testing and services. It was a South Africa partners meeting where they looked at the gap. So we're all trying to get that 1.1 million clients onto ART. And this just shows the breakdown by province and what that gap is. So just remember that we have the largest HIV population in the world. And that HIV transmission is not driven by occupational exposures. It's driven by non-occupational exposures. And if we look at the data and we look and see, we don't have, if we still need to find 1.1 million people who are not on ART, those are people who can transmit HIV. If we look at the people that are having viral loads that are unsuppressed, particularly those that are above 1,000, right? Because U equals U, then PP becomes a vital part of our prevention arsenal. However, what percentage of those who are most at risk, because P populations are the drivers, they're more than half of the new infection, HIV infections, are aware of PEP and what is the access. So when you look at the comprehensive HIV prevention approach, right, we've got the ARV-based prevention, and right after PrEP is PEP. This is just some data, and it's very, very old. I'm sorry. This is probably not going to be a reflection of where we are right now. But this just take a look at the last column. At a PHC level, what is the facility coverage? That means facilities that are actually providing post-exposure prophylaxis. You can see many of are providing, and now this is almost all green except for the Western Cape in current terms, right? And except for Limpopo, but in terms of PEP, the numbers were very low. When you look at the numbers of people that we are looking at, just in terms of those that would require PEP, remember we said 408 infections a day. We can see that for this annual target 22-23, the target was about 15,000, and they'd initiated about 11,600. So if you think about it, this data would probably largely be confined to sexual assault victims, because that was the main indicator that we had, and or occupational exposure. And so I thought I'd take a look and try and find some data about occupational exposures in South Africa. And so I wasn't able to get real-time data. So there are these papers that were looking at occupational exposures in the different, healthcare settings, and looking at many of these reviews looked at nurses, they looked at doctors. We've also got some that look particularly at paramedics. And whilst I'm not going to go through each of these individually, right? So what we can see is that occupational exposures, because the latest data that I have is from 2020. And so you would, in your facilities, be able to understand what's happening at your hospitals, your clinics, your CHCs, etc. So we can see that some were as low as 10% here in Tygerberg, where they had exposures of 10% of those nurses that they interviewed, to 77% in 4 hospitals in Gauteng, right? And this is where they looked at intern doctors. What is striking to note is that there are some older studies. So this study that you're seeing is a rather older study where more than 60% did not even report their exposure. We have a range where about 46% reported, 59% reported, and these who got PEP, these are the percentages that reported. With EMS personnel, you can see that 89% of them initiated on PEP. But when we're looking at the rates of PEP completion amongst healthcare workers, right? So in the healthcare workers that completed, we're looking at between 44% and 83%. So these are healthcare workers that are working in dangerous environments, exposed to these materials, and they were not able to complete it. And have that thought in mind when we think about our clients that we are seeing. I also need to note that in some of these studies, the PEP regimens that were given were 2 drugs and not 3 drugs. And so if we are giving PEP now, the standard is that we should be giving a 3-drug regimen. So when we review the occupational injuries data, you can see that all cadres are affected. We've got a lot more data on nurses, but there were also some places where there were very low rates of reporting. And some of the reasons that were reported in these studies was, number one, they didn't know where to report and how to report. There were some concerns about confidentiality, especially with the HIV testing, and some said they sought help outside the facility. Some said there was a lack of time. They didn't have enough time to go and report and manage it. Whilst for others, there was this perception that the source patient was at a low risk for having HIV. What we do know is that we didn't get 100% PEP initiation rates, because people did not come forward for it. And the completion rates were quite low, except among the EMS personnel. Some of the studies looked at knowledge about PEP. And so in some of these studies that they looked at all of this data, it's also important to note that they did asked questions about PEP and when PEP should be taken, and there was some inadequate knowledge. But these are older studies, remember, not much more recent studies. So when we look at in your workspace, occupational exposure prevention, because that's the first step, looking at standard precautions. So you call universal precautions, right? Just around our hand hygiene, the use of gloves. Can't tell you how many times I see nurses, doctors taking bloods and doing all sorts of things with the sharps in their hand, and they're not using gloves. And they'll tell you, I can't find a glove to fit me. You can't feel the vein. I need to feel the vein, etc., etc. And obviously the manner in which we dispose of sharps. We know that now we've got more safely engineered needles, so needles that can retract once they've been used. We've got sharps containers that are less hazardous for when we're disposing. And I believe there's even some needleless IV systems. Looking at, making sure we're not recapping needles, making sure we're disposing of contaminated waste and these needles appropriately and right after we use them. The use of kidney dishes in transporting shops, containers, etc. And so training and awareness, not just once off, but regular training on the risks that are involved in the workplace, safe handling, and the post-exposure protocols for access to the drugs, and then how we report on these. Vaccination for hepatitis B is crucial, and I'll talk a little bit more about that, as well as post-vaccination antibody checking, boosters or revaccination for non-responders, promoting a culture of safety and reporting so that we can reduce underreporting. And when we do, so in those studies that I showed you, some people had 3 exposures in a year. And so if I'm an individual, or we having 1 or 2 exposures in a year in the same individual, it's important that we try and understand why these events are occurring so that we can put systems in place to minimize the reoccurrence and improve on the implementation of our IPC protocols. You saw healthcare workers don't finish PEP. I know you'll even find it difficult to finish a week-long course of amoxil. So it's really, really important that in our occupational health spaces that we have support for completion and follow-up. So based on that data that I showed you from the PEP access at PHC level, these training slides and job aids were introduced in 2024 to increase healthcare worker capacity to provide PEP as an emergency intervention. Almost the same approach that you would have to a DKA, that you would have to an unconscious patient. You need to have an urgency when it comes to dealing with these kind of cases. And so in 2023 of April, we had this new data element that was introduced to the NIDS, which is persons exposed to HIV who tested HIV negative and was issued with post-exposure prophylaxis new. The other 2 here about sexual assault cases seen and new sexual assault cases offered ARV EP was there. We've done this slide several times, understanding pre-exposure prophylaxis. This is in the context of HIV, post-exposure prophylaxis, which is 3 drugs within 72 hours of somebody having possible HIV exposure, and is continued for 28 days, and then lifelong antiretrovirals. But this is not the only form of post-exposure prophylaxis. You've got hepatitis B prophylaxis, tetanus, STI, and rabies, we're definitely not going to be covering. So this is very old data, but why 4 weeks? Why isn't it 3 days or 10 days or 14 days? And so very, very long ago, this data was published in 1998. They did this study where they injected these macaques with SIV, which is very similar to HIV, and PEP was initiated 24 hours after they were inoculated. So some got 3 days, some got 10 days, and some got 28 days. And what we can see is that when they were given PEP for 28 days, the rate of seroconversion was 0. We also had 4-week case control studies which used 28 days. And certainly it's going to be very difficult to do a randomized control trial when we have a medical emergency on our hand and say so-and-so can get PEP and so cannot. And so we are using 28 days based on the data that was supported there. But why the 72 hours? So this image is looking at the critical early steps in the transmission, usually sexually, of HIV. So you've got the HIV at the mucosal lining, and these purple dendritic cells are what they would encounter there, right? Whether it's at the vagina, the rectum, the urethra. And these dendritic cells, they don't actually kill the HIV, but they transport it to the nearest lymphatic tissue. And so they would take it to the local lymph nodes to present them to the T cells, who are then going to produce antibodies to kill them. We also have macrophages that engulf, and this is not a whole lecture on that. I want to get to the timing. So the time it gets from entry to get to the lymph node is about 1 to 3 days. Local amplification in the lymph node takes between 3 and 7 days, and then systemic spread starts from day 7 to 14. So if we're going to get PEP in, we've got that 1 to 3 day window. The earlier, the better. Certainly within 24 hours, it's the best response that's been seen, but up to 3 days. After 3 days, there hasn't really been much benefit, and that's why there isn't any benefit because once it's amplifying here, this is now where it's explosive within the lymph nodes. And so we do it for 72 hours because of this. So that first question where I asked you, what is the risk of, this is a systematic review that estimated the per act HIV transmission risk, right? And like I said, blood transfusion and vertical transmissions not in here. So when we're looking here, we can see that a partner receiving anal intercourse is the highest risk. So this is 1.38% if you look at it, right? The risk per 10,000 exposures. When we look at needle sharing, it's 63, right? Needle sharing injections, percutaneous healthcare workers, it's 23. And there's lots of data that lists that occupational percutaneous risk at about 0.3%. There are variations as to how this risk could change, right? So if it was a mucous membrane exposure, a splash in the eye or the nose or the mouth, that's 0.09%. You can see that receptive penile vaginal and insertive penile vaginal, the risk goes down. And certainly a lot also depends on viral load, the amount of the inoculum, etc. So what we know from a literature review in 2016, where they were documented 10 seroconversions amongst healthcare-related exposures. So these occupational exposures have resulted in cases where the healthcare worker has seroconverted. So they are not innocuous or something that we should not be thinking about. And when you think about a healthcare worker, don't just think nurse, etc. Think about your cleaners or anybody handling medical waste who may be exposed, and the need for them to understand that. So one of the things that I thought about, I'm looking at my time, 1905, is how do we identify clients that are presenting and who need HIV PEP in your facilities? Is it okay for us to open the mics? I just wanted to understand, in facilities, how are these clients being identified at the moment? Lesejo?
Yes, I was just unmuting. Colleagues, feel free to raise your hand if you would love to respond, and then I'll give you the the mic. I'll allow you to speak. You can raise your hand. Okay, thanks, Tandi. Tandi, you may unmute. You may unmute. Yes,
Can you hear me?
loud and clear.
Yes.
Okay, good evening, colleagues. So I'm working for an organization as an EMART nurse. So usually in our organization, we have a questionnaire on the system. The questionnaire goes like, in the past 3 days, did you have unprotected sex anally, vaginally, or orally with somebody that you know might be HIV positive, or someone who you do not know their status? The moment the client say yes on that, it closes, it reads the rest of the questionnaire, and then the person is automatically transferred for PEP. And then if that one they skip, but the second one they say they've touched somebody's blood, and then also it automatically takes them to the need for a PEP. So that's how in my institution we screen them.
Thank you.
Thank you. Thank you so much, Tandy. And so I'm assuming we've got colleagues that work in different levels, and you may be working in a facility, you may be at a PHC level, CHC, hospital level, right? Or you may be working on outreach. And I want you to think about this, right? Think about if you have a waiting room in your facility, could there be clients that are sitting there that need PEP and they don't even know it? Somebody that's coming in for their NCD treatment who's had a sexual exposure and we've never ever explored it. Is it only our lay counselors? Do our lay counselors ask clients about those questions which Tandy told us about, to understand before they're doing an HIV test, would this client require PEP? If you're working in a casualty and somebody comes in to a casualty and they've been involved in some form of trauma, are we evaluating to look to see, is there a need for HIV PEP or Hep B PEP? Because most times people will not walk into a facility, right, where the sexual assault protocols come into play. But oftentimes what we think is your PrEP clients that are coming in to your facilities, just remember that clients can present in so many different ways. We ask about people in sharing injection because sex is not the only way. Are people using injectable drugs with one another? So think about that when you have a busy waiting room. Because remember, we've got a 72-hour window. And when that client enters our facility, we're not quite sure where they are. So I just thought that I just wanted to highlight that. And so most of us in this room would know the infectious fluids, blood and blood-stained fluid. So, the fluids that are infectious for Hep B, HIV, and Hep C, right? From the blood-stained fluids to tissues, to intimate partner fluids, to body cavity fluids, and breast milk. And then those that are non-infectious, right? That when people are exposed to this, we don't need to worry about it. And so this is the take-home message, right? That when we see somebody that's had an exposure, we don't let them go sit in the queue to go and have HIV testing, where there are 10 patients that are waiting, because time is of the essence, right? When you are dealing with your clients that are already on PrEP, and understanding if they've had an exposure, are they covered or not? WHO, this is guidance from the 2024 WHO guidelines. We're waiting to see if our PEP guidelines are going to follow these guidelines. And I've spoken to you about CAB and Depivirine vaginal ring. The guidance for CABIA is a little bit different from our guidelines, just in terms of when PEP will be provided, because WHO says if you more than 7 days from your scheduled injection date, and you've had an exposure, we should be offering you PEP, right? And that's any exposure, not just sexual exposure. The other thing is with regards to oral PrEP, with the ring, right? The ring takes 24 hours to become effective. If you've had sex in the period before the 24 hours, you need post-exposure prophylaxis. If you took the ring out for any reason, right? Or if you have the ring in, but you've had other exposures like anal sex or other types of exposures, then you need PEP. And so for men, you know, when we're thinking about sexual exposures, right? And if they're having sexual exposures, they need 4 tablets in a week in order for them to be covered for their sexual exposures. It's a lot higher for women. You need 6 to 7 tablets. And so CDC has very different guidance to what WHO says, especially when it comes to occupational exposures, because oral PrEP in the context of PWID and the reduction in risk is a lot less than for sexual exposures. And so they would still give PEP even if you had adequate doses of oral PrEP, 2 drugs on board. They want a 3-drug regimen. So what NDOH produced was this clinical algorithm and lots of lovely job aids. And you can type in the chat and let's say, can let us know if you've seen these, if you've been trained on these, because by now you should have been trained on these, right? So immediate services that people need is first aid if they're required, especially from the occupational standpoint. If somebody comes in and they've got trauma, they're a sexual assault survivor, and then we need to establish PEP eligibility, right? And get that first dose in as soon as possible, and then we'll look at all of the other aspects related to care. So when you look at the algorithm says confirm that they've had an HIV exposure, that it was within the past 72 hours. If it's yes, you're going to look to see, are they eligible for TLD, right? Because that's our preferred regimen. We're coming to that, right? Were there any contraindications for them to be getting TLD? And then you want to get the first dose in. And so this guidance has come in, even if you look at in the case where we have an occupational exposure and the person who's exposed doesn't want to have an HIV test, they will still get PEP. In the WHO guidance, right, the absence of an HIV test does not negate the provision of PEP. That first dose is the most important dose, because we want to get it in as soon as possible, and we can conduct our HIV test. Obviously, the person that you would need to explain to the person about the PEP, why they would need PEP, all right? And what is going to entail with the PEP, and that can be a short discussion, and they consent to it, and then you'd give it. If they're above the 72 hours, then there's no PEP for them, right? Because they're outside of the window in which we would act. And the testing we're going to do depends on your client based on their age and whether we're doing rapid testing or whether we're doing a rapid and PCR, especially if they're 18 months to 24 or they're above 2 years, etc. So this is what that top half of the algorithm would look like. It's saying, identify if there's been a potential exposure, right? Give them the stat dose, right? And for yourselves, when we take you through the rest of the slides, we can look at that. One of the things that I want you to think about is algorithms are wonderful, but we have to operationalize algorithms. And how does that look like? So Tandi's told us what that looks like in her outreach or her facility, in her organization where she works. What does that look like depending on where that patient is, right? what does this look like in order for somebody to get the stat dose? And then looking at the potential exposures. If they test positive after your first dose, it's not a train smash, because now we're going to talk to them about the ongoing need for care and treatment services for their HIV. And we'd offer them all of the other services that we would to somebody who was testing HIV negative and is going to go on to PEP or is not going to go for HIV or is not. Because clients can say, no, I don't want it. All right. And then we need to look at the SRH needs. We need to look at GBV and IPV, especially if we're dealing with our younger females that are coming in, reviewing the need for PrEP afterwards, right? The mental health screen and substance abuse screen, so that it's a holistic package that we're looking at and not just HIV. So this is with the question that I started in that earlier slide, right? What does this look like in your out? So if I'm in a mobile out in the community, because one of the big pushes that WHO, and we might see it come out in the guidelines, and this was what PEPFAR was speaking about as well, is I'm out in the community, I'm seeing an individual, and I recognize the need for PEP. Now I've got to leave wherever I am, and then I've got to go all the way back and take them to a facility for them to get PEP. So what does the process flow currently look like if we have an occupational exposure and inadvertent exposure for our trauma or sexual assault survivors, depending on whether you're in a casualty or a maternity ward or in the medical ward or in a general outpatient department or PHC level? Or, like I said, somebody just goes for HIV testing and one of your counselors identifies. It's going to be important for us to go back to our places of work and think about that, and go back and look at your protocols that you have in your facilities and look at your process flows to see, is this working well for us? Do we know it? Does everybody know it? Does the cleaner know it? Right? And then if I'm in a private institution and it's after hours, or I'm in a public institution and it's after hours, what does this protocol look like? Because it's wonderful to have protocols, but then we have to begin to operationalize them. So this was the question that we asked you earlier. Which 3-drug regimen is preferred for those exposed? So this is where I think the guidelines are going to lead to. So if you look at the 2020 guideline, the 2020 guideline has a weight of 35 kilograms, because at the time it was written, we could only give TLD when you were 35 kilos. That's now dropped, and we think it's going to go here to align with the ART guidelines. So if you looked at this, our preferred regimen, if you are 10 years and weighing 30 kilograms, is TLD. Simple, one drug, easy to take, and we all know how to do it, right? It is a 4-week regimen, right? We don't give 3-day starter packs to people, right? That talk of a 3-day starter pack, I found it in the PHC standard treatment guidelines, right? It's the only place I found that. I didn't find that anywhere else when you review it, because WHO has become very clear. In the standard treatment guidelines, the 2024 PHC one, it says, if somebody refuses HIV testing, you'll give them a 3-day pack and continue counseling them so that they can have an HIV test. Right? You won't find that in WHO, and we're waiting to see what the formal PP guideline is. In the training slides, you will not find that either. So for our children that are under 10 years and under 30 kilograms, using the PEAS dosing chart, we're also waiting to see if this is going to change. So the backbone is AZT3TC with dolutegravir. The alternative is going to be AZT3TC with atazanavir, ritonavir from 10 kgs, or with lopinavir, ritonavir twice daily if they're under 10 kgs. And in this 2020 guideline, right, the abacavir was a third option if there isn't no alternative. So we're waiting to see if this is going to change or not. But this is what is currently in the guideline for children. And I've already told you about this slide. I'm sure most of us on this training likely understand that when we give dolutegravir, it's important to understand its interactions with rifampicin and the anti-epileptics, where we do need to add the additional 50 milligrams 12 hours after the TLD dose. And that if we have diabetics or and metformin, we should give a maximum dose of 500 twice daily. And that for our clients that might be taking over-the-counter supplements like magnesium or calcium or iron, understanding that if they're going to be taking this together, right, TLD must be taken with food, or we're going to separate it out. And if they are on any antacids, you know, and they're on dolutegravir, it's a really, really complicated scenario where you just have to start your antacids 2 hours after the DTG dose, and then you have to stop your antacid 6 hours before. So that's something that's going to be really tricky in our clients. And then if we happen to give PIs, because remember, PIs are now second choice, right? The first choice is going to be atazanavir, ritonavir. The second is going to be lopinavir, ritonavir, and it's simply because of the side effect profile. We also need to understand the drug interactions that protease inhibitors have, especially with enzyme inducers, just like dolutegravir, and then some NCD drugs like our calcium channel blockers, you know, where they increase the levels of the calcium channel blockers. Or if somebody's on H2 receptor agonists like cimetidine or ranitidine, I think most people, they're probably not going to be on that. They might be on omeprazole, which can increase effect, you know, that's on atazanavir, but no issues. So we don't co-administer atazanavir if somebody has to be on omeprazole, right? Theophylline, we shouldn't really have many people, but if we do, we should not be giving the PIs with theophylline. And then if there are any clients that are on warfarin, etc. And so my gold standard is, I don't know every single drug interaction. And so I would put in whatever drugs the client is on into the Liverpool interaction checker, or if you've got the little guide that's come from UCT, and just look to see quickly. When you need to understand the side effects of these drugs, because that becomes important when we're talking to clients, so that they familiarize themselves. We know TLD is generally well tolerated, you know. We know that there can be GI side effects, but these are generally more mild. And we know that they can have occasional insomnia. This is a 28-day regimen, so we're not worrying about weight gain, right? And for the clients that are going to be on PIs, right, especially if they're going to be on atazanavir, so that they don't get shocked when they get jaundiced, right, and then they think they're dying. So because of the unconjugated hypobilirubinemia that atazanavir can cause, or a rash. And we know that AZT and lopinavir, ritonavir, the GI side effects are really, really bad. So if we are going to be putting our clients onto those drugs, it's really important. I don't know how many of you have been on PEP. I've been on PEP, right? And I was on the AZT3TC Alluvia regimen. Guys, everything you see written here, I had. I couldn't go to work for 3 days. It was horrible, right? So it's important for you to understand fatigue is a real thing. The GI upset is a real thing. The diarrhea is a real thing. So it's important. So if we can't give TLD in those who are 10 and 30 kilos, right? Then we, like we said, we can add the additional dose if they're on enzyme inducers. If if the DTG is contraindicated, we spoke about the atazanova which is the preferred dose, because it still gives you a once a day dose. Or then we have to give the allopurinol alluvia, the allopurinol ritonavir. If your client has compromised renal function, these guidelines speak to AZT3TC, and then you would dose adjust your 3TC to 150 when it gets down to 10 mils per minute, and then less than 10 mils per minute, you dose adjust both your AZT and 3TC. When it comes to clients that are failing therapy, right? The golden rule is that if you are unsure, you need to understand which regimen they're on, which regimen they are failing, right? We know now that our primary regimen is TLD. A lot of us might not know the source person, but if we've got, especially if you've got those who we are unsure about, your helplines are available. The guidelines used to say that if they were failing a TDF-based regimen, give AZT3TC and dolutegravir. If they were failing an AZT-based regimen, you give TDF, the TLD, right? And if they're failing an alluvia-based regimen, right, that you would consult. Right now, we know that the levels of dolutegravir resistance in South Africa are very low. They are not anything to write home about. And so it would be a very rare occasion where we would need to, if you are concerned, there are many helplines that you can speak to. Talk to your patients, right? When I got my PEP, no one told me the side effects. I was fresh out of medical school. I'm ancient. So in those days, you know, we didn't even have ARV treatments for our patients at a facility level, right? And so clients need to understand, and looking at when somebody's been exposed to an infectious fluid or substance, you need to gauge when your conversation, how much information can they actually take in, right? Would they be able to understand how to take the PEP, what to do if they miss a dose, the use of condoms because they've now been exposed and may have HIV, right? But it's just not manifested yet. Understanding those side effects and how to manage them. When do they need to come back to you? Discuss looking at their risk profile. Is PrEP a good option for them when they finish PEP, right? Or if they are on PrEP now, what happens after they finish the PEP? What blood tests we're going to need to do on them? Why are we going to need to do it on them? I've not included those related to the source because usually we don't have those, right? And then guidance about not donating blood until we have followed you up in the follow-up period because of the risk. This was the second question. No, this was not. I didn't ask you this, right? So in the interest of time, I'm going to go through this with you on the next slide, because in my question to you, I'd asked, is hepatitis B surface antigen routinely done? The answer is no. And here's why. If I am somebody who's been exposed to an individual, right? All of you here know that we do an HIV test and an ELISA, if available, right? If I'm under 2 years, that's going to be a PCR in our baseline visit. We want to do a hepatitis B surface antibody. Why? If I want to understand if somebody needs hepatitis B post-exposure prophylaxis. What's going to tell me that is their surface antibody, because it's going to tell me about their immunity. Are they immune to hepatitis or not? So in somebody who's exposed, an antigen is not what we want to know. We want to know in the source whether they're infected. So there we do an antigen, but not in the person that's exposed. The hep C antibody is usually usually done if we know the source is antibody positive, or we don't have the source with us, but there's a high likelihood that they may be at risk of HCV. So they were an injection drug user, as an example, right? The guidelines are saying that if it's sexual exposure or the source is positive for syphilis, we would test for syphilis. And this is where I think guidelines are guidelines. So if we look at the data for syphilis right now, if I have somebody who's coming in and they've had a sexual exposure, you can use your clinical judgment, because in the guidelines, it's about the source. The 2020 guidelines just mentions the source must be syphilis positive, right? Nowadays, you might even have the dual syphilis testing where you'll be able to check, right? Creatinine if they're going to be on TDF, and FBC for the AZT. Pregnancy testing our females that have a sexual transmission or have an occupational exposure as well, right? We want to know what your pregnancy test is. The antibody test can be omitted if we know the person that is exposed is immune. So at 6 weeks is what the guidelines will say, we call you back. If somebody is going to transition to PrEP, when they come back at 4 weeks, we would do these tests on them, right? So if they had the antibody at baseline, they would get the PCR. And if they've not had a normal period, we'd want to check their pregnancy because we would have given them. So when you look at WHO speaks about doing testing at 3 months. So does the SA HIV Clinician Society. When you look at our guidelines, it talks about 4 months. So baseline, 6 weeks for those not going onto PrEP, and 4 months. When you look at the training slides, they've told everybody to come back at 4 weeks, right? Because then we can transition them to PrEP. And here is where if we did an antibody on them, right, and we either have vaccinated them and given them immunoglobulin or not, we want to now do a surface antigen because we want to see if they were infected, right? If we know the person's immune already at baseline, these are not being done. And then if they were vaccinated, we wait 1 to 2 months after their last dose, after that 3rd dose, to check their surface antibodies. And that's an important step. So here, what I just want to bring you to is Hep B prophylaxis. If we've had a perinatal or a needle stick exposure, we can give this within 7 days. Within sexual exposure, we can give it within 14 days. Don't forget we'll talk about emergency contraception within 5 days. STI prophylaxis, if required, within 72 hours, and then tetanus prophylaxis, if need be, within 48 hours. Hep B is more of a threat than HIV when it comes to exposures. It is 50 to 100 times more infectious than HIV. And with that question that I asked you about the risk of transmission, it's Hep B, then it's Hep C, then it's HIV. HIV is like 0.3%. When the data that was quoted in the PEP guideline was 30%, the risk after. So when somebody comes in for PEP, Hep B is the first thing I'm thinking of more than HIV, especially in a healthcare worker. So what do? So most of the times we're not going to get the source. So let's assuming, right, that the source is unknown. Because if the source is positive or unknown, remember what we are going to do is we're going to look at our source, our exposed person. Are they vaccinated? Are they unsure if they're vaccinated? Is the vaccination complete or is it incomplete? If they were vaccinated, what's their titer level? Because they need a titer level of 10 in order to be immune, right? So if we don't know all of this, we're giving them immunoglobulin and we're giving them the vaccine, 3 doses at monthly intervals, right? If they are immune, you don't need anything. They're immune. They were vaccinated, their surface antibody titers They are safe. They don't need any further prophylaxis. I don't even know if they did my Hep B titers when I had, and I never ever got any immunoglobulin. If we happen to have the source and the source is negative and our exposed person is all of these above, then we need to formally vaccinate them. So the formal timing of vaccination is month 0, month 1, and month 6. This when we give the vaccine at 3 doses, right? So Hep B immunoglobulin it provides these passively acquired antibodies for immediate protection. And so it can be protective of up to 70%, especially if it's administered soon after the exposure. The immunoglobulin will last for 3 to 6 months, which gives your vaccine time to build up your immunity, right? So the combination is very good. And then it's really, really, really important to know that once we have vaccinated somebody, we need to come back again after they've done that, right? Check their Hep B surface antigen to make sure they were not infected, and check their antibody titer to see whether they are immune or not, or whether they need to be vaccinated again. So I'd looked at this, right? Hepatitis B vaccination coverage amongst healthcare workers. This was a study that was done in 2022 in a tertiary hospital with 460 healthcare workers. 2/3 were less than 40 years and had worked less than 10 years, with about 50% being doctors or medical students, and just over 40% were nurses or student nurses. Other staff that were part of this were lab staff and cleaning staff, right? No, lab staff and the student and the cleaners and students. Only 49% of those healthcare workers were fully vaccinated, and only 15% had immunity testing post-vaccination, with nurses and those with more than 10 years experience being more likely to be vaccinated, right? Cleaners were less likely to be vaccinated. So I think for yourself, it's important. Do you know your Hep B immunity status?
Rochelle,
I've had to have, hello?
I hope you can see me there on the references, colleagues. It's not me, I'm just happy to see Bawela there.
Oh, sorry, Doc. I didn't even realize that was you. Ah, wonderful. So it's important, right? Emergency contraception. Remember, if we've got females that are presenting to us, right, and we especially with sexual exposure, we need to look for their breast cancer staging. If you are unsure, give the emergency contraception when you detect any breast development. We don't need them to have had their first period. It's important to also understand that the two emergency contraception is levonorgestrel 1.5 milligrams, or else your copper IUCD. And note that, this can be vomited out. We need to repeat the dose if it's vomited out within 2 hours. And we need to double dose if somebody's on enzyme inducer, or their weight is more than 80, or their BMI is more than 30. Presumptive STI treatment. This is in particular for our sexual assault survivors. Refer to the pediatric dosing for children, all right? And it's generally not indicated in your usual birth condoms, etc. It would be up to your clinical judgment if you see an indication for that in those cases. And then lastly, these are the PEP tools that we have to complete. So you can see the top section is very similar to our oral prep form. So that's the demographics. Then the next section will talk about when did the exposure happen? What was the time? Do we know what type of exposure it was? Is it occupational, consensual sex, or non-occupational, or suspected sexual offense? And then the next section under that is where we place the results from the baseline and the other investigations that we do. You can see this tool was developed with those training guidelines, so you can see that it's at 12 weeks and not 4 months as you see in the guidelines. Right. The next section will talk about, was the person eligible for PrEP? Did we start it, and the commencement date, the time we took it, the time that first dose was given. So the time of exposure and the time we gave the dose and the regimen, right? And then you'll see a note there that when clients have left us, we would have told them when we're going to see them again. The advice is, if we can contact that client within the first couple of days to help them along, especially if they are having side effects, is indicated. And then lastly, the other exposures, right? So sexual exposure, were they on contraception or not? Did we refer them for any other service? And what happened at our follow-up visits, right? So was the repeat test negative? Did we put them onto ART? Because we're trying to look to understand the rates of seroconversion. Did we refer them for PrEP? Yes or no? You can see here, they said that this client was referred because they came back and they were still negative, and they were referred for PrEP, and then they came back at 12 weeks. Remember, they're going to come back at 12 weeks. And then there's a section at the bottom where you can write notes if you called the client. This is a really nice diagram which shows you came here at month 0, we started you on PEP, we guided you to be able to take PEP for the full 28 days. When you come back at day 28, we're going to do your HIV test. If your HIV test is negative and there's no indication why we cannot start PrEP on you, and you are willing to start PrEP, we start you on PrEP, and then you follow our PrEP follow-up schedule. You come back after a month, then you can give an MMD after that, right? And don't forget, if this client that got HIV PEP also was vaccinated for Hep B, remember, please document when they should come back for their next Hep B injection and when they should have their antibodies done. So this is my last slide, colleagues. My key takeaways. Please regard HIV PEP service as a medical emergency. The first dose can be given before HTS. We don't know when that client is coming in that 72-hour window. The earlier we can get the first dose in, the better. Don't let them sit in the queue waiting for a lay counselor. Take them in if you are the nurse or if you are a visiting doctor or whoever. So I think this is also important, right? I'd advise all HIV negative clients, PrEP clients, on when they can access, when they should access PEP. And if they are on PrEP at the moment and they know they've not been taking their PrEP well, WHO has guidance to say, tell them, if you have an unprotected sex exposure, take the 2 tablets and come straight to the facility to get the 3rd drug. So this is the kind of information we should be given. We now all know that TLD is the preferred regimen. We offer the full PEP package, not just HIV. We counsel clients well so they understand why they need to be on it, what's going to happen after they leave us. Ensure that we have ongoing healthcare worker training on our IPC protocols so that we can encourage a culture of safety and reporting to minimize occupational exposures and take a quality improvement approach. We don't want the same healthcare workers having 3 episodes in a year. And encourage all facility healthcare. This is from me, right? Because I didn't know my immunity was low. And when I went to another NGO, they did it as part of our onboarding to know what our immunity was. And then I had to be revaccinated. So please make sure we know our Hep B immunity status. Thank you. So now we're going to go back to the polls. To the polls.
Yeah. Do you want me to run them for you, Rachel?
Yes, please, because
Okay.
I put the ones with the answers.
Okay, let's start with the first one.
I'm sorry, I know there was a mouthful.
No, it's okay. It's okay. It's okay. We are empowered, so we are very happy because tomorrow we will be better than we were today. That is the most important thing. Yeah. So which statements are correct? I see the yeah, regarding the risk of transmission. Rochelle, are you still there?
Yes, I'm there.
Oh,
I'm
okay.
in the poll.
Okay, I'm gonna stop. Colleagues do participate, but we'll move on. Can you see the results, Rochelle?
Yes, we can see the results. So wonderful. 58% of you got this correct, right? So receptive anal intercourse is the highest risk, right? And so it's important, especially as you are considering, remember, half of our new infections are from key pops. Next slide.
Okay. Question 2. Let's rerun. Okay. So do you guys
So
agree
here,
with the sequence?
you got, we're going to get dilution here.
You want me to stop so that you see the 100%? Nah, there'll always be me. There'll always be Dr. Mawela there diluting the 100%. So let me stop and show
So
the
we've got a
results.
lot more, right?
Yeah.
So yes. So those of you who said that the risk of transmission is highest for Hep B followed by Hep C, that is true, right? And I think I remember the first time I said that to a group of healthcare workers, they were like shocked. That risk for Hep B is actually highest. We can go to the next poll. So can the first dose of HIV PEP be given before the HIV test?
I'll tell you.
Yes.
If you get 100 on this one, I'll give you 1 rand. But it's better. You can see the
Yeah.
it's now way
So
better.
last time we were here on 40, I think 48% of you said no, and
Yeah.
about 43% of you said yes.
Yeah. And
So
now we
here
are.
we can see, so we've got somebody that's still not sure, and that's okay, right? And so we can stop share, we can
Okay.
share. So yes, colleagues, right? And I think, you know, when you, and here's the problem, right? Because when you read some of these guidelines, you read them say, you know, and that's why I read to you from the actual guidelines what they are saying. So if you read the PHC guidelines, the treatment guidelines, those are the ones which say you must do an HIV test first. When you read the 2020 NDOH guidelines, those are the ones that where they said, well, if somebody refuses an HIV test, you go ahead and give them the PEP anyway. So we don't actually need that test. If somebody, it's not going to alter the result of my test if I take PEP. It's not going to alter that HIV test result, right? What we are going to do is if somebody has been exposed and may be infected, we are going to catch them really, really early. So don't be afraid. And WHO has also said HIV testing or the absence of it should not be a barrier to say somebody must wait in a queue to go and have an HIV test before we give them that first dose. Thanks.
Okay.
Next
so I'm
one.
going to number 4, ne? Yeah.
Yes.
Okay. There we go, colleagues.
Which is the preferred regimen if you are 10 years and 30 kilograms?
Almost 100%. Almost.
Right.
We gotta stop, colleagues, because I know when you get to
Thanks.
2 something, it gets a bit slow. Yeah, there we go.
So there are some people who are thinking a Bacavir-3-TC dolutegravir, some people who still want to give AZT3-TC Aluvia or atazanavir ritonavir. So the guidelines are here, right? we are giving TLD. Number one, it's the most potent drug. It's a once-a-day tablet. And if there's no contraindications to it, the side effect profile's not all that bad. So that's the drug we want our clients to be on. Next slide.
You mean next poll? Let me try.
Poll, yes.
I almost went through the slides. Okay, good. Colleagues. Let's
Do
go.
we do a hepatitis B surface antigen when we are giving a PEP after unprotected sex? I'm going to say it again. Do we do a surface antigen when we are giving TLD? And I think this one, you can stop it.
Okay.
Let's say we can stop it.
Okay.
So for this one, remember, I'm exposed. I want to know if I'm immune to hepatitis B. And so if you go back and read through your serology, the way that I know if I'm immune is I must do an antibody test. But on the source, the person that I was exposed to, I want to know if they are infected. So we will do an antigen test.
Okay, the season finale. Oh, you're still
The
explaining,
great
sorry.
news is the job aid has this all nicely. The algorithm, if you forget, the algorithm's got all of it there. It's not a trade smash. And the last question.
Season finale. Let's go for gold.
So if we have a healthcare worker with a needle stick injury and their surface antibody titer is 10, right? And we don't know what the source's antigen status is.
Read it carefully, colleagues. Low
Right?
risk or high risk?
Is this a low risk or is this a high risk? Who will not get PEP? Who will get PEP? And what is the hepatitis B PEP we give? I'm going to close it there because we are back to where we were.
As I said, should I say, I mean, is it low risk or high risk, colleagues? Is the health worker protected? Do you know the source's status? Right. I mean, those two, when you combine them, for me,
the health worker, the health worker is protected if their titers are 10 and above.
You see.
So these titers are 8. So the titers they're not immune. So because they're not immune, right? We are going to give them immunoglobulin because we don't know the source. And we're going to give them the vaccine 3 doses, right? And the units for the immunoglobulin is 500. So number 3 is the correct answer here. The second one would be right if we had our source's results and the source was hepatitis B surface antigen negative. So they don't have hepatitis, but we know that our healthcare worker has no immunity, right? So we need to vaccinate them and we give them the routine vaccine schedule. Thank you.
And colleagues,
thanks, Lesego.
Yes, I wanted to also emphasize that, remember, colleagues, the vaccine, the effectiveness will only happen a little bit later. If I remember, it's about 6 months or so. So we need passive immunity. That's why we give immunoglobulins for the immediate protection. For the immediate protection. So that's very, very important. Even before Rochelle taught, I remember I kept on saying high risk because I perceived the health worker to be not protected. And the client is a potential positive person because we don't know their status. That's why when we ran the poll initially, I just said high risk, because I was looking at
you're thinking VTP, ne?
Yeah, low risk, high risk. I'm trying to make sure.
Low risk, high risk.
And actually, it's a very simple question that if you ask yourself after you see your the patient, the health worker, you're asking, is it low risk or high risk? If it's high risk, you must protect. If it's a low risk, it means you can get away with just vaccination or even doing nothing. If the health worker is immune and the source is negative, I mean, why would you see? So low risk, high risk, because sometimes I'll be thinking, what did Rochelle say? You see, so at least low risk, low risk, high risk. So what I want to do, colleagues, quickly before we go through the questions, is just to encourage some of you to join our membership program. Let me see if I'm able to pull it off quickly. Yeah, just to say that if you're interested in our membership, actually, let me refresh this page, because once you type www.clinicalcareplatform on your website, I don't know if you guys can see the website, you'll let me know. You'll see this orange banner
Yes,
here. Already it's telling you that you can actually learn more about the membership option, or on top there where it says CPD membership, you can just click on the menu there. And if you click on either the green thing on top, written CPD membership, or that banner, it will take you to this page, and then have a look there. Already we tell you, if you join membership, is the best thing you can ever do for yourself. Over 160 live webinars that we do every year, and you'll get CPDs. You'll get immediate access to over 150 on-demand CPD courses, right? And you can read and read more. We've now issued over 120. So we actually make it real that it's something that we deliver on. But I want to show you, I've logged in. I don't know if you can see on top there. I want to show you a few things, and then if you you see, I've logged in, and as soon as I log in on the platform and it recognizes me as a member, there'll be this section here written my dashboard. It doesn't show up unless if you have logged in, right? Let me show you my dashboard so that you can see what your colleagues are enjoying. And remember, it's 1,200. You can start today, you can start anytime. You don't have to start in January. It will last for 12 months from the date of you joining the membership. Look at that. I'm being called by my first name. Hi, Lesijo. Look at Rochelle smiling. I can see Rochelle is like, yeah. I hope it's calling you by name, Rochelle. If there's no name, colleagues, you must go and update your profile. Next to your name there, just update your, your profile. But already you can see we have a number of communities so that you don't miss anything. But what I wanted to show you is, firstly, look at this. It says Lesejo continue learning. So it means there are courses I had started and I didn't finish. So nutrition, I'm at 20%. Just imagine I'm training on guidelines, but I'm at 11%, If you go there, it says something new. So sometimes you don't know what to study. So every time we upload new things, like today's session, it will be here as a micro lesson. You can review the material, you can pause, rewind, Dr. Rochelle, and also download the guidelines, which we will upload with the course. You can see I haven't done anything recently, so I'm a defaulter. It also says sometimes you see, there's things I've completed, by the way, like polyuria. Maybe I had polyuria myself, and I wanted to just check what did they say about it, and maybe I want to just learn. But what I want you to appreciate is this part. I mean, on the new, let's go to the new ones quickly. As I browse to the right, so there's an arrow there. I hope you guys can see that arrow. You just browse to the right, like your Netflix. You can check everything that has been uploaded recently. You just click on it and start it. This is part of the 150 thing. And then look, surgery. If you are interested in surgery, is the same. You can use this arrow there to scroll or even check out all of the things we have under surgery: internal medicine, infectious disease, radiology, pharmacy, obstetrics. I don't know what you guys like, etc., etc. If you think of it, many people spend a lot of money on continuous professional development, and I don't have a problem with that. I think it's good that we must commit to making ourselves better people. So I don't mind if you want to do that. But what I can always question is, why are you not a member? I mean, that is the biggest question. Why not? Why not? Why
that's my question also.
Because
There are
To
so
be
many
honest,
benefits, colleagues.
yeah, there's and
So
when you,
many benefits.
yeah, and when it's time for
Like
what is,
I missed Leon's talk on
yeah,
innovative prep.
yeah,
And so
prep.
I want to go back
You
and
know you're
do the
gonna go
micro
back,
lessons.
So I don't know, So I
Yeah.
want to encourage you, colleagues, to reflect on your commitment, and I see you enjoying the lessons, but also maybe do it as a social responsibility. Support the platform so that you can continue to get this awesome. I mean, look at what Dr. Rochelle has done today. A lot of work, a lot of reading on her side. 5, 6 guidelines to put it together just for you, Actually, no, let's go through the questions because we don't have a lot of time. Colleagues, we're gonna continue just for 10 minutes. We don't have a lot of questions. Rochelle, when you asked how people know if someone needs prep, condom best. Maybe here I would like you maybe to just talk about the importance of person-centered care, non-judgmental. Because I know when the condom is best, the first thing I get is a scripture, and someone wants to be my mother and tell me, how, or some people feel that it's intentional, or I don't know. There's a lot of, that's why young people don't even show up. They just go to queue there at the private pharmacies and pay. Your comments?
So remember, right? I don't even need somebody to come in and say that a condom burst for me to get post-exposure prophylaxis.
Mm,
Somebody can just come and say, I didn't use a condom.
mm,
I
mm,
don't know, it was a one-night stand. And so one of the things that we have to do as healthcare workers is look at, remember what I said to you, most transmission is not occupational.
mm,
And even though from a sexual transmission perspective,
mm,
the risk per 10,000 exposures is low, we have almost 8 million people that are infected. We've got more than 1 million people that are not on ART. And today people are having sex. Tomorrow people will be having sex.
mm,
And so our role, and I'm very, very much now into preventative medicine.
mm,
If we can prevent somebody becoming infected with HIV,
mm,
even though there's treatment available, there are other issues that are long-term complications we really do need to prevent. So look at them, smile at them, take them non-stigmatizingly, like our sister Tandy said, we have a protocol once we identify somebody so that we're not drawing attention to the person
mm,
and say, we're going to take you. It doesn't matter if it's a 13-year-old, 14-year-old, because that's the
mm.
program I was dealing with. Yeah.
Awesome, awesome, awesome. Anonymous is talking about the drug-drug interaction between metformin and TLD, and that the guidelines have been updated. Please make sure you read
I'm
them.
not familiar.
Yeah, I wanted to
I,
comment.
I've not, I was going to ask you, Lesego, is there a new
Yeah.
guideline I'm not aware of?
There's no new guideline. So, firstly, there's no guideline that has been updated, but there is guidance from the Cape Town hotline, which is circulating, but our guidelines are not yet updated. I know
Updated.
the consolidated HIV management guidelines are about to be signed. So, AHD, everything would be there. We will assess if they align with the Cape Town advice. But even that, you need to read. It still talks about that limitation, but it explains context under which you may still continue to use DTG if your patient is on a higher dose of metformin. So I can't mention it because we have to wait for the national, because the question is about guidelines, so we know. So yeah, we and obviously today's talk is a little bit further from this, but Anonymous, we note that, and I'm aware of that document. And Rochelle, I will share it with you. Just remind me on WhatsApp, just for you to have a look at it. Yeah. So Nomthandazo says, please repeat. Can I do hepatitis B to a patient who's starting PEP or PrEP?
So if
Yeah.
you have somebody who's been exposed,
Hmm.
right? And there is a concern that they've been exposed to somebody who is hepatitis B unknown. It's more obvious in an occupational exposure. But if you think about it, right, our HIV prevalence rate is sitting at about 7.8%, thereabouts.
Mm,
Hepatitis B surface antigen is sitting at 6.7%.
mm,
That's a huge amount of people with chronic Hep B.
mm,
And so you're doing the surface antibodies in an individual to
mm,
understand if they are immune.
mm,
For an occupational exposure, you have a 7-day window, and perinatal exposure where we give it.
mm,
Then for sexual exposure, sexual assault's a lot easier because you're going to give it anyway.
mm,
If you have somebody with a human bite where there's exposure to blood, especially hepatitis B, prophylaxis becomes very, very important. And so it's for the Hep B, if you're doing a surface antibody on somebody,
mm,
it's to give them post-exposure prophylaxis.
mm,
If you want to start somebody on PrEP, you're doing their surface antigen because
mm,
we want to know if they are infected with hepatitis B or not, and whether when they stop PrEP, is there a need for them to continue to prevent the flare-up?
mm,
So I'm not sure if that's what she was asking, but I
mm,
hope I've answered you, Nomtandazo.
mm, mm. Awesome. Even for PrEP, I think it's not necessary, isn't it? There's only specific patient populations, or is it necessary to do it for all? I know
Well,
when
our
you have to
guidelines
stop.
haven't changed.
Yeah.
Our guidelines haven't changed. We're waiting. They
Okay.
were looking at
Okay.
a consolidated prevention guideline.
Okay.
WHO says you can do it within 3 months, but
Mm,
our guidelines currently still have Hep B there
mm.
at the baseline visit, simply
Yeah.
because we've got quite a high chronic Hep B
Prevalence.
population. Mm.
Yeah, I would generally want to know the status anytime I need to interrupt PrEP versus I don't think it's something
Yes,
that would make me not to
it's
give PrEP
it's
because I'm waiting for
no.
hepatitis B. I think that's what we need to make
No, well,
sure. Yeah.
okay. Yeah, no, we
Colleagues,
don't need to
because
wait
he's
for
asking
that
for both,
result
you
in
see.
order to
So
give PrEP.
yeah, yeah,
Yeah.
yeah. All right. But before you stop, always you need to know the state. Yeah, Trifina says, in case where a patient is taking PrEP, do we still give TLD for PEP? So it's trying to assess
So,
the effectiveness of
yes.
PEP for PrEP exposed patients. Yeah.
So if we have somebody that is on a PrEP method, right? We assess to see how adherent are they
Mm,
to that PrEP method.
mm,
And for males, it depends on whether it's oral, whether it's the ring, whether it's CAB. And there's specific guidance that tells you
mm,
that they don't have sufficient levels. Occupational exposures,
mm,
and especially where there has been exposures to blood,
mm,
TLD is going to be given.
mm,
So if I'm on CAB and I'm taking my injections on time every time,
mm,
and I have exposures, even if I have an occupational exposure,
mm,
I'm not going to take TLD. I'm covered,
mm,
right? There's nuances, and that's why I'm waiting for the guidelines now to see what they're going to say, whether they're going to follow WHO, which speaks to how many tablets do you need to take, even in the case of an occupational exposure. Like I
mm,
said, CDC says in the case of an occupational exposure, we
mm.
want 3 drugs on board.
I want to ask you a question. Obviously, it's from me,
Sure.
and obviously, it's a very simple question with a simple answer, depending on whether you are right or left. But I know nationally there is no agreement between public sector and scientists. So, if the source patient is on ARVs and fully suppressed, what what are you?
So, so,
Yeah,
so and even when you read the HIV Clinician Society guidelines, right?
yeah.
U equals U is only proven for sexual exposure.
Okay.
It would depend on the exposure. And I think that there are varying scientists who will say, no, we don't need to. And there are others that will say yes.
I think policy makers will say
Policy make
yes, but I think
yes,
scientists will say there's no science behind giving if it's a sexual exposure and the source patient.
it's sexual. Yes,
Yeah.
sexual exposures are clear.
Sexual
Sexual
exposure,
exposures are
the
clear,
source patient is suppressed.
suppressed.
You even can I ask?
You reassure.
Can I make it even in a sexual assault scenario? You yeah, as you counsel the patient and you know the source patient is on ARVs and suppressed, you would still not. Okay, what I'm trying to ask, are there medical legal, not scientific, but medical legal indications to give it? I don't know. I'm just thinking. I don't
Yeah,
have an
I
answer.
do think, in the space of sexual assault, I think that's where a lot of people might have different opinions.
Yeah.
It's different from consensual
Mm,
sexual partners where we know that that person, because here it's trauma, there's a whole lot of other things that are
mm,
involved.
mm,
And so these are the conundrums that we are going to have, right?
mm, mm.
These are the conundrums that we are going to have, and that's why I'm waiting to see what the
The
updated
guidelines.
guidelines are going to say,
All right.
because if WHO just says any exposure, so if
Yeah.
we on cab and we have any exposure,
Regardless.
you know you just carry on your cab.
Yeah.
So I think when we're dealing with oral and all of these other things, it becomes an issue. There
Awesome.
is no
Awesome.
Hep B cure.
Yeah. No. Actually, there is. The only cure is your immune system. So for
Yeah.
HIV negative people, I think, but isn't it they say by 6 months most people can clear it on their own. But if you fail to clear it by 6 months, you have lifelong infection. If you are HIV positive and you get hepatitis B, we don't you have lifelong. Your immune system can never clear, generally speaking. So I think, yeah. So there's no treatment, as in drugs,
No,
to cure it.
there's
Yeah,
no, yeah, Hep C we can cure. Hep
yeah,
C we can cure, not Hep
yeah,
B.
yeah.
And if the immunity to Hep B vaccine is decades.
Mm, mm,
It's decades. And so they're also not quite understanding why we have non-responders to vaccine, which
mm,
means that if you've been vaccinated, please go and check
mm.
whether
Your
your
levels.
titers are where they need to be, because
Mm.
it's decades.
Yeah, I don't know if you know about this. In the national STI meeting, this was discussed. This doxy prophylaxis for STIs. I don't know if you've. But I mean, Mervin, what
Um,
Mervin is asking, maybe is there other things we may need to prevent, especially for sexual exposure, be in addition to
well, I think
HIV?
that
Yeah.
the challenge is, though, that it's been primarily completed in MSM populations,
Mm,
key populations, if I can understand. And so I think also the numbers and looking at the the policy, we need to understand the use in females. We
mm,
know at the moment we're not even doing the 211 in our MSM population.
mm.
So
Awesome.
I think these are that's definitely what a lot of scientists are looking at.
Mm.
I need to go back to IAS to see what they were talking about as well with regards to that.
Yeah, I actually want to show you something. Matapelo is one of the nurses I've worked with and trained. She says when you showed your research and there was my surname because it reminded me of a study I was involved in. In my early days, I thought I was going to be a researcher.
A researcher.
Yeah, let me just show you. I just want to show colleagues what we found, some important things, and maybe for you, Rochelle, it will be then your own reflections, colleagues. In my early days, colleagues. Now I hope you can the real one now, not that one. But look at what the study is all about. This was very interesting, Rochelle, because it talks about the prevalence of active hepatitis B amongst health workers, right? Then there's this occult hepatitis B. People who, if you do your surface antigens, they are negative, but when you do the viral load, the DNA is there. I just want to
Wow.
highlight what some of the findings were. If I was to zoom in, I hope you can see. So you can see here, so if you look at health workers who received at least one dose, it was 70%. So most of us don't complete the 3 doses, right? 9% were
Yeah.
already infected. And when I did the talk on
Wow.
ethics in HIV care, I was asking about the risk of us infecting our patients and what are our responsibilities. And health workers tend to feel, no, we don't have, no one has to know unless if we have infected the other person. But anyway, 30% already showed that they were exposed. So they had markers to show that they were recently exposed, as we did this particular study. 18% were immune due to natural infection. So we do get infected, and our immune system sometimes is good enough to respond. But look at this, hepatitis DNA was detected again in about 9%. And there was a group where only the DNA would have been positive and the surface antigen, which we rely on, was
Yes.
negative, you know. And then the conclusion was that there was a high rate of active hepatitis B and suboptimal protection against hepatitis B amongst health workers. And what is not covered here is that there was a questionnaire, and in the questionnaire, health workers, after needle pricks, they are just worried about HIV. This thing of hepatitis B is secondary, but hepatitis B can be a big problem with cancer, hepatocellular disease. So usually we don't take hepatitis B seriously, you know,
That's very
which
true.
is
Very, very
yeah,
true.
we're just scared about HIV. I don't know your comments after seeing those numbers there.
Well, and that's the flip side, right?
Yeah,
The flip side is us knowing our health
yeah.
and knowing our risk to patients,
Mm,
especially then our IPC and how we manage ourselves.
mm,
You know, because we know that if I'm a healthcare worker and I have HIV, I can be suppressed on treatment. But most people don't know about the
mm,
HIPAA, which is what you are saying,
mm.
and they don't even know whether
That,
they're immune or not.
no, they just want TLD.
A lot of studies have been done in Gauteng, guys. So if you're in
Yeah, Gauteng and
Gauteng, most of
Mpumalanga.
the
Yeah,
studies,
this time around.
thing,
Yeah.
you know, that study was done with over 400 workers
Yeah,
in Gauteng at
Gauteng.
different levels of care. 49% were fully vaccinated. I'm shocked.
Yeah,
I'm shocked.
40.
I was shocked when I read that study.
It's
And so that's
half.
why
Mm,
my takeaway, colleagues, is treat PEP, especially for HIV, as an
mm,
urgency.
mm,
You
mm,
don't need to wait for that HIV test to give the first dose if your client is eligible for it.
mm,
Number 3, know your own hepatitis
mm,
surface antibody status and your immunity as you are in the workspace.
mm,
Number 3, please make sure that you have clear protocols and training
mm,
in your facilities so that your system, whether you're at a PHC, a CHC, or a hospital, knows how to manage occupational injuries
mm.
as well as clients who come
Clients.
in and
Mm,
require PEP.
mm.
Those will be my big 4 takeaways.
Awesome. Let's take the last 2 questions and call it a night. Rochelle, Amos he oversees a district, actually a metro. So you must get the answer otherwise. So he says, I'm still not clear on PEP for clients who are taking PrEP. Do we only give those who
Okay.
have had an interruption or, yeah.
Okay. So if I am an oral PrEP client, which is what's available primarily now, would be my assumption. Colleagues can tell me if that's not the
Mm,
case.
mm,
What we need to understand is it a male or is it a female? And we need to understand the exposure that they're coming in. So if I'm an auto prep client and I'm talking about sexual exposure, I need, as a male, 4 tablets a week on board. Then I don't need PEP. So if I'm taking 4 this week, 4 next week, remember, I'm having ongoing sexual exposures. My PrEP is covering my sexual exposures. If I am a woman, I need at least 6 tablets weekly to get the levels of the TDF and FTC at a level to protect me. So if I'm not having those levels, right, then, and I have an exposure, I need to get PEP. I hope that clears it for you, Amos.
Yeah, Amos, drop me a WhatsApp because I know you very well, and then we can always.
Okay.
Yeah. So some Anonymous says, is it only health workers who get hepatitis B vaccination? I think.
No,
Yeah.
children
Yeah,
all
all
got Hep
kids
B
now.
vaccine.
Yeah, it's part of the.
Kids from 1995
Yeah.
got Hep B as part of the EPI, right? So unless the parents opted out, right? And I'm not sure what the availability of Hep B vaccine is, but Hep B vaccine is part of our EPI, and hopefully people are getting vaccinated against Hep B, but we give it in particular settings because of the risk. Healthcare workers, correctional centers, etc., lab workers, because they deal with fluids that are highly infectious.
Awesome. Can we repeat PEP? Is the last question, colleagues. Apologies. We have went way beyond time, but I'm hoping you have grasped the situation.
So I came and I got 28 days of PEP. Today I finished my PEP, and in 2 days' time I have another exposure. I'm going to start PEP again.
It's very important.
Right? And so clients, remember, there's no long-term, it's not like CAB, where CAB is staying in your blood for a year, right? If I stop taking PEP and I have another exposure, I need PEP again. And so those are clients that once we see them for the first time and we see them again and again, we need to start talking to them about PEP.
Okay.
So the second time they're coming into you, we're talking about PEP. And it's another 28 days.
Awesome. Just to say, hepatitis are available in the API program. Yes. So I think we can take this. Because I thought maybe there's many questions. This is, if we answer this one, it's like all the questions for tonight, which is fair for everyone. So Anonymous says, if you vaccinate against hepatitis B and have immunity, do you not still need to check your immunity after 10 years? And if you need a booster? He's actually teaching us, but indirectly, Anonymous.
Yeah. So the literature that I looked at notes that hepatitis immunity lasts for decades, 30 decades and beyond. We check immunity after 10 years to see whether we are still immune. And if we are still immune, then you continue. So I started medical school in 1990, giving my age away, 92, right? And we all got our vaccinations in that first year. And then when I joined an NGO in 2013, they did my antibodies for me. And they found that my antibodies were low. I'd never, ever had my titers checked. So I was not a part of EPI. So the only happy I got was when I entered medical school. And so I then was vaccinated, and then they checked my titers for me afterwards to make sure that I was now immune. And I think if people are not responding to vaccines, that's when we send you to the specialists.
But after 10 years, you must check, and if it's less than 10, you need boosters, etc., etc. But you saw in these studies that are done, we don't complete the 3 doses as health workers, And then never mind the checking for the booster because it's
Checking.
10 years. Maybe we forget. I don't know occupational health and their responsibilities to
Are
remind
there
us
any occupational health
in that space.
on the call?
Yeah,
Yeah.
and when we get exposed now, you saw in the study there were people who were recently exposed. We just want to know HIV. If HIV is not there, these other things we hope that we will survive. So don't forget, hepatitis B is such a big problem. Colleagues, that's it. Apologies for keeping you until this late, but I'm hoping as you look at the overall session, you are really happy that you've been empowered. If you are a member, you will get access to the micro lesson so that you can replay, maybe even play it there in your clinic with your team so that you can improve how you care for people who need PP, but also you respond appropriately for people, health workers and staff. Dr. Rochelle, thank you very much.
I was just
Yes.
wondering, Lesego, are you still working in the provincial sector? Those job aids and the fact sheets and all of that, are they available at full facilities? Because I can
They should
contact your
be.
HAS coordinators so
Yeah, they
that you can
should
get
be.
access to it.
But you know, Rochelle, you know, we know what the ideal and there's always a gap between. But these are things that are supposed to be in every facility. We are supposed to have trained all facilities because there was a campaign nationally to revive PEP, especially the last 2 years. And those targets, you saw how small they are. I don't think there should be a target. Every single person who needs PP must
Every
get
single
PP.
person.
But yeah, the issue. So the simplest answer is
Yeah,
yes,
Lucy wants to
but
know how to
there's the
become a
reality.
member. Lesego, Lucy wants to know how to become a member.
How to become a member. Okay, I'm sharing a link, Lucy. It's there. Just click it. Otherwise, drop us an email. Let me try and see if I can type it. info@clinicalcareplatform.com. I'm not sure if, because I did a very quick thing on the website. I don't know if Lucy saw it because we didn't have enough time. I've shared the link. I've also shared I hope I typed it correctly. Yeah, the email address. Drop us, and then the team will be happy to help you. But there's great value in the membership program. All right, night, Dr. Rochelle. Keep well.
Sorry, Lesego.
Yeah,
One more thing.
yeah.
One more thing, please. In sexual assault cases,
Mm,
please prioritize PEP
mm.
before the police.
Yeah, please prioritize everything,
Please.
even immediate care. Some of the clients need
All the
urgent care.
PEP must be a
Yeah,
part of immediate care.
yeah.
Thank you.
Yeah, I worked in that space for over 15 years, Rochelle, at Jubilee Hospital there. And we were running a center separate from the casualty. But I tell you, it's like you are in casualty. That's how bad things are and can be in South Africa. So it's a space I understand very well. So, and sometimes people need like urgent care, like maybe they're injured, and
Injuries.
everyone
Yes.
focuses on that box. No, you don't have a box. Go and get the box, but the person can't breathe. So it's very important that we don't forget to respond optimally. And colleagues, on Wednesday, I'm going to do a webinar for it's a Women's Month thing. I'm hoping that it will help many of us who've been through difficult times and or we are going through it now. And the truth is, difficult times are coming our way. If either in the past, now, or even ahead. Pain is just part of life, but there's you can actually embrace it and find a way to come out as a warrior. So yeah, that's what we are going to discuss. Can't wait for it. Sharp. Bye.
Right.
Bye, guys. Hey, this webinars. Hey, bye.
Missed our latest webinar? No worries. We know life gets busy, but your professional development shouldn't have to wait. That's why we've created webinar micro lessons. Short, focused recaps of our full sessions designed to help you catch up quickly and still earn your CPD points. These bite-sized lessons are available exclusively to active subscribe members. So even if you miss a live session, you never miss out on the knowledge or the CPD points. Not subscribed yet? Now's the perfect time to join. Get access to all future webinars, every micro lesson, and more. Visit www.clinicalcareplatform.com to sign up.
Year-old known epileptic is in the ED following a seizure. While awaiting further assessment, you are called to see them for another seizure. You perform the ABCDE assessment, which is airway, breathing, circulation, visibility, and exposure, ABCDE. Secure the airway, so you intubate the patient, and you give them 4 milligram of IV lorazepam, which is otherwise called Ativan. Blood glucose is normal. After 5 minutes, the patient is still seizing. What is the most appropriate next step? Is it A, give a second dose of Ativan, B, monitor for 5 more minutes, then a second dose of lorazepam? Is it C, transfer the patient to the ICU, or is it D, a phenytoin infusion? So the concept that they are testing here, guys, status epilepticus, okay? So they want to know what's your approach to status epilepticus.